Hi, this is Darcy Gaydon recording a review for the Integument Eye-Ear Unit with the primary focus being on burns and functions of the skin as well as glaucoma pathophysiology. Those are the items that really have information that I think warrant talking about in a PowerPoint with narration. Not that it's more important information, but the rest you've had in class already. The layers of the skin, just to review, we know we have the epidermis, the dermis, and the subcutaneous tissue or adipose. And primarily, you do want to be able to know what the main functions are of each of these layers. And if you recall, we talked about the epidermis being the barrier, of course, to the external environment. It's replaced every 3 to 4 weeks, and it contains keratin, protein, that forms the barrier. It also repels pathogens and protects from invading bacteria. We know that we have phagocytes in that area of the skin also that, again, protect from invading bacteria. We have the melanin, of course, that protects from UV rays, and the melanin is stored within the epidermis. And then another important function is really to maintain the hydration status so that we're not losing excess fluids and electrolytes through the skin. The dermal layer then is primarily responsible for regulating our body temperature and thermoregulation, and also is the conducting agent for the nerve endings and the CNS transmission. So we talked about with, for example, third-degree burns, there's typically no pain because the nerve endings within the dermis have all been destroyed, and so there actually is not pain, and the pain onset is later with third-degree burns once they start to have nerve regeneration. And then the subcutaneous tissue is, helps with connecting skin to bone, muscle, and other skin layers. It provides that cushion, and it also has some insulation properties as well for thermoregulation. But the primary function of thermoregulation lies within the dermis. So what are the functions of the skin? You should be able to readily identify what these are. Again, protection. The epidermis is only 1 millimeter thick, but it has very effective protection. And again, we talked about that we do have thickened skin on the palms and soles, the palms of our hands, soles of our feet, to protect us more readily because we do have constant trauma to those areas. Sensation is an important function. We do have receptor nerve endings in the skin to allow us to sense temperature and pain and touch and pressure. And certainly we do have more nerve endings in our fingers as well, because that is, again, an area that we need very particular and sensitive sensory function. Fluid balance, again, the outermost layer of the skin, the epidermis, has the capacity to absorb water and prevent excessive water and electrolyte loss from the skin. It helps us maintain the moisture that we need. Now, we do lose some water via evaporation or sweat through the skin, usually an average of 500 to 600 mils a day. But for example, fluid balance and fluid loss is one of the major complications of severe burn injury, and a person could be losing 5 to 6 liters of fluid through the skin during those times of major burns. So it's a very important function of the epidermal layer. Temperature regulation, then, remember, this is taken place in the dermal layer, the dermis, and again, the skin is going to prevent excessive heat loss, and on the next slide we'll talk about how that happens as far as vasodilation and vasoconstriction. Vitamin production is another important function. The skin is exposed to UV light, and with that converts substances necessary for the synthesis of vitamin D. So certainly sunlight is important for that vitamin D synthesis, and we know that we need vitamin D in order to aid in calcium absorption. And then immune response function, we have several cells, phagocytic cells within the epidermis and many other immune cells within the dermal layer that help with the immune response and protecting against invading bacteria. In addition to, of course, the actual layer of skin that certainly protects us. This slide then does look at body temperature regulation, and again, blood flow through the skin vessels is controlled by the sympathetic nervous system. So our receptors, our hot and cold receptors that you see, are located in the dermis, those actual skin vessels, but the actual temperature regulation really is regulated through the sympathetic nervous system. So if we look at the right side, for example, it's an example if you have a fever. So if we have a fever, that fever is going to produce vasodilation. So you see where it says blood vessels dilate, sweat glands are active. We usually are sweaty and moist, and we have that red hue to our skin because of that vasodilation and increased blood flow to that area. And our hair lies next to our skin. And basically, via that vasodilation, results in more heat being delivered to the skin and therefore a greater rate of heat loss from the body. So that's how that vasodilation is causing us to hopefully lower our body temperature internally. So vasodilation, increased blood flow to the skin, that's why we get our red hue. And again, as we have more heat being delivered to the skin, we do have a greater rate of heat loss from the body, ultimately lowering our body temperature. On the left side of this slide, it's the opposite. And so if we're cold, our blood vessels will constrict in the cold. We know that. We know that ice helps constrict. We know that if you're outside in cold temperature, we have vasoconstriction. So when we have vasoconstriction, our sweat glands, of course, are inactive. We have shivering. Our hair may stand on end. And now we have decreased blood flow to the skin, resulting in our pallor, or the pale color of the skin. And with the decreased blood flow, we actually have less heat being lost through the skin. So more of it is being conserved, and we have our body temperature rise. Okay, moving on to burn injury, there are 4 major goals of burn injury, and really just quickly to highlight, prevention is the key. And so we talked about the table, the chart within your textbook that talks about burn prevention, talks about education of kids and not playing with matches and stoves, and having safe bath water temperature. Changing the batteries on your smoke detectors and carbon monoxide detectors, every 6 months, typically with daylight savings time changes. That's a good time to do that or teach to do that. So there's lots of things that we can do for burn prevention. Institution of life-saving measures, the initial treatment will always be ABCs and removing any burning clothing and cooling the burn and wrapping in a sheet and all of those kind of life-saving measures. But again, starting with the ABCs. And then certainly prevention of disability and disfigurement through early treatment. The sooner that we can get to a burn trauma unit to not only help with the life-saving measures, but also to help with the early treatment and grafting, or the actual synthetic dressings that are used instead of the actual autografts to help with early treatment, reduce scarring and disfigurement and reduced contractures, and all of those things can be impacted with early intervention. And then certainly rehabilitation through reconstructive surgeries and rehab programs for both the physical needs, psychological needs, and then also we talked about the vocational rehab or retraining that is sometimes needed for employment following a major burn injury. Classification of burns is very important that you do understand and can recognize what an assessment of a burn looks like as far as the burn depth that you are anticipating based on what you are seeing. So again, you do have a table within your textbook that delineates the different characteristics of burns according to depth, and you really should be able to identify some of the potential causes of a first degree burn, for example, what layers of the skin are involved, what does the wound look like. And again, there are, you should be able to recognize both names: superficial partial thickness or first degree, deep partial thickness, which is second degree, and then of course the full thickness, which is third degree. We don't know which way you might be seeing it on future testing or NCLEX, and so we want you to be able to recognize it not only as first, second, and third degree, but the actual longer names for the burn depth. And then, of course, you do need to be able to also calculate total body surface area injured, and we will primarily be concerned with, or want you to know, the rule of nines, where they assign a percent in multiples of nines, and it's a quick way to calculate percentage. And you do have the body with the percentages of in nines in your handouts that we talked about in class, as well as a practice problem. Now, the London-Browder method is a more precise method. It accounts for age and body surface area, and in kids accounts for the larger torso and head. But again, you need a chart. You would be using this in a specialized burn trauma unit, and so we wouldn't expect you to be able to calculate that without that information right in front of you. And then the palm method is when, if a patient has scattered burns, it's very useful for that. You can take the size of a patient's palm, and the size of a patient's palm equals about 1%, and so you can count how many palms you have to get the percentage of total body surface area. Now, backing up just between first, second, and third degree, just want to quickly mention that first degree, is certainly the epidermis that's involved and possibly a portion of the dermis. But the biggest thing with the superficial partial thickness or first degree is that it is reddened. You have redness, as you do with second degree, but the redness blanches with pressure. Typically, the superficial partial thickness is dry, whereas the second degree you'll have weeping and edema. Now, you may have blisters with both first and second degree burns. That's a possibility. And certainly you have pain with both the first and second degree burns as well. Now, the second degree burn, again, as we said, pain, red, mottled, blistered, and edema and weeping surfaces. And then the full thickness or third degree, you will see more of the dry, pale and leathery, black, as far as eschar, edema, and certainly you can see all the way down to bone at times, and certainly signs and symptoms of shock, most definitely in third degree burns and in severe second degree burns of a large body surface area as well. If we look at the pathophysiology then of local and systemic responses to burn, the first and foremost that we're looking at really is the hypovolemia, or what's called burn shock. This is an immediate consequence of fluid loss. Again, we have a massive amount of fluid loss through the skin, the area that's open, once that epidermal layer is gone. And also we have hypoperfusion and organ hypofunction due to the hypovolemia. So if we think back to fluid and electrolytes, again, we've gone over it a few times now, and in the renal unit, what happens when we have decreased blood pressure or decreased volume or hypovolemia? The first thing that happens is we have a sympathetic nervous system stimulation. We have a decreased blood flow and decreased perfusion to the kidneys, and so and with that is because of the sympathetic nervous system stimulation. So the sympathetic nervous system stimulation, we'll see the elevated heart rate. That is our compensatory mechanism. We'll see vasoconstriction, and again, with that vasoconstriction though, we have an increase in afterload, right? If we have vasoconstriction, we have a greater amount of systemic vascular resistance. Our pump has to pump harder to eject that blood out to the peripheral circulation. So we certainly will have decreased tissue perfusion and a further decline in cardiac output. So decreased blood pressure, elevated heart rate, that decreased blood pressure and decreased volume will stimulate the sympathetic nervous system response and decreased renal perfusion. Now, the greatest fluid loss is initially in the first 24 to 36 hours, really peaking by 6 to 8 hours. But it certainly is significant as far as signs and symptoms that we're seeing. And then as far as the fluid shift, we've kind of talked about this already, but we basically have what's called burn edema, massive burn edema, and we have loss of that capillary integrity. So we have fluid shifting from the intravascular to the interstitial. So, and again, we have that hypovolemia, our vessel doesn't have volume, all of that fluid is moving out into the interstitial. Again, think about how much protein is within our dermis and epidermis, and basically we don't have that protein anymore to maintain osmotic pressure. So that is why, part of the reason why we have that massive fluid shifting from intravascular to interstitial. Now, even in a localized burn, just even a first degree or just a mild second degree burn, we have blister formation, and that is the fluid shifting. That's the same concept, but it's localized and it's not systemic. So in a major burn injury, we most certainly will have generalized edema, a massive generalized edema. And again, you have their maximum edema in 24 hours and resolved within 7 to 10 days. Most burns, the edema starts to resolve within 1 to 2 days once we can maintain that capillary integrity and start to get fluid shifting back from interstitial to intravascular area. Now, hyponatremia and hyperkalemia. Hyperkalemia is a direct result of cell lysis, and we have trauma. The cell trauma and the cell destruction that occurs with burns is going to shift potassium out of the cell. I mean, potassium is normally housed, the majority of it housed intracellular, and so once we have cell destruction, the potassium has to move out. Now, the sodium-potassium pump is in place that if one moves out, the other moves in. So if potassium moves out, sodium moves in, and that's why we end up with a relative hyponatremia. Increased hematocrit, this is due to plasma loss and that hemoconcentration. We have a small amount of volume, and so our hematocrit is actually elevated, it's concentrated. Typically, you'll also see red blood cell destruction, and with the red blood cells, you're losing platelets as well, so there could be a decline in platelets and red blood cells. Other responses, systemic responses, one of the major areas, of course, is the inhalation injury and what we call carboxyhemoglobin. And inhalation injuries are the leading cause of death in fire victims. And, with the inhalation injuries, we have basically catecholamine release, and that's a stress response, right? Catecholamines, epinephrine, norepinephrine, those are what we call catecholamines. Those are released, and those further decrease blood flow to the periphery. In later stages, we have hypermetabolism. After about 24 hours of the burn injury, we go into a hypermetabolic state, and this further increases oxygen consumption, which when we already are having respiratory difficulties, it's actually, it's not a good thing to have more oxygen demand when we have less supply of oxygen. Now, the biggest thing also with burn injury is looking at this carboxyhemoglobin. What basically happens is carbon monoxide will combine with hemoglobin to form carboxyhemoglobin. So instead of oxygen binding to those hemoglobin sites, we have carbon monoxide binding to the hemoglobin sites. So with that, certainly we have decreased tissue perfusion. We have decreased oxygen carrying capacity of those hemoglobin molecules. And so they do need 100% oxygen to help with the ventilation and tissue perfusion. 100% oxygen is also going to accelerate the removal of carbon monoxide from the hemoglobin molecule. So we need 100% oxygen to perfuse the tissues adequately in the time being, and we also need the 100% oxygen in order to start removing some of the carbon monoxide molecules from the hemoglobin molecule. Now we also have bronchoconstriction caused by the histamine release with the stress response, and so bronchoconstriction can further narrow the airways. And then we can certainly have chest constriction, in particular if we have a circumferential chest burn, meaning that we have burning on both the anterior and posterior side of the chest. It goes all the way around the chest, and so with that we can have constriction and edema. It can act like a tourniquet and just tighten up that ability for the lungs to expand for adequate respiratory function. As far as renal function alterations, this is a direct result, again, of the decreased blood volume, decreased cardiac output that will automatically, compensatory mechanism, stimulate the sympathetic nervous system. And sympathetic nervous system will send less blood supply to the kidneys and send more to the brain and the heart. And so when we have that stimulation, we have decreased renal perfusion, which results in, decreased urine output. As far as immunological defenses, certainly sepsis is one of the leading causes of death. If thermally injured, we know that we have decreased leukocytes and lymphocytes to help with that, and we certainly have the broken epidermis and the phagocytes that are there to protect against that. Open body cavities, and so certainly sepsis and infection is a big deal. Body temperature changes, again, we have the loss of the skin that regulates the temperature, the dermis. So we initially, in the first 24 hours, 12 to 24 hours, have hypothermia because we're losing all of that heat through that skin. Once we can get that skin covered, we actually then revert into a hypermetabolic state post-burn, in the post-burn period. Paralytic ileus and Curling's ulcer, we know that we will have an increase in hydrochloric acid production during the stress response of a burn, as well as a decrease in the mucosal barrier within our intestines, and so we are at much higher risk for what's called Curling's ulcers. Those are stress ulcers, and in either gastric or duodenal ulcers and erosion. And we'll talk more about that in the GI unit. And also, we know that we have decreased blood flow and tissue perfusion to the GI tract in general during a burn, because that's not a organ that's high priority. And so there is a normal finding to hear absent or hypoactive bowel sounds, and there certainly is a potential for a paralytic ileus, in which we kind of treat prophylactically by putting in a NG tube and by having the patient remain NPO during that time period. This graph initially probably looks really overwhelming, but I just want to mention that it just is, if you can understand this flow diagram, you truly understand the pathophysiology of a major burn injury. And don't get worried about where all the arrows are going. Don't let that mix you up, but if you can kind of make the associations here, I think you have a good understanding. We'll just kind of briefly, because a lot of it is what we just talked about, but we'll just briefly cover a few items on here. Major burn injury at the top, it does say greater than 30% body surface area, but really in your textbook, it's greater than 25% body surface area for adults and greater than 20% for children. And not that you have to memorize the number, but it really is a good idea to kind of have that number in mind as far as when it falls into the major burn injury. And also keep in mind that all chemical and electrical burns automatically fall into the major burn injury. They will have a systemic response that we see here on this graph. If you go to the right, that's just kind of the initial response. We have, because of loss of skin barrier, we have thermoregulation problems, and we have a decreased inflammatory response and an impaired immune response. Those are the functions of the epidermis and the dermis. So if we have a loss of that barrier, we know that we're going to have problems in those areas. It also describes possible inhalation injury, and with that we certainly could see hypoxemia. If you go to the left of that table, then it looks at cell lysis. And again, with a major burn injury, we have drastic cell destruction and cell lysis and breakdown of cells. So potassium is kicked out of the cells, and so we have a hyperkalemia. And then we do again have breakdown of red blood cells, or hemolysis, and destruction of the red blood cell will produce a decreased hemoglobin. Now, coming right down the center of this graph, then it really starts with talking about those fluid and electrolyte changes. And we have that increased capillary permeability, or that loss of that capillary membrane. And so with that, we have sodium and water and proteins. We have all of that fluid shifting from the intravascular to the interstitial spaces, resulting in our decreased circulating blood volume by up to 50%. So we most certainly are going to see circulatory shock or burn shock. So with that, we have the sympathetic nervous system response and the stress response. Again, it's not just the sympathetic nervous system, it's the hormonal response, the adrenocorticoid and the catecholamine response that we just talked about in endocrine. So all of those hormones are being released in addition to the sympathetic nervous system stimulation, because we have decreased blood pressure and decreased cardiac output. Now, if you look at the hormone response, you go over to the left and it's telling you, okay, there's peripheral vasoconstriction. We know that that is because of the sympathetic nervous system response. But with that, again, we have an increased afterload, or increased systemic vascular resistance. Our heart has to pump against a larger amount of pressure, and so we have a decreased cardiac output, or decreased amount of blood ejected by the heart. We have tachycardia, again, sympathetic nervous system response. We're expecting a high blood sugar. This is the normal stress response. We are expecting increased catabolism, where the body is going to be in a hypercatabolic state. It's going to be breaking down protein for energy sources for the cells. The risk of Curling's ulcers and secondary gastric bleeding ulcers that can happen. And then again, the hypermetabolic state, after the burn shock resolves, we go into that hypermetabolic state in which we have an increased oxygen consumption and oxygen need. So all of those things are resulting in decreased tissue perfusion. Now, decreased tissue perfusion affects all of our organs, right? And so it affects our kidneys, and we have decreased renal blood flow and the risk of acute renal failure, and we'll see decreased urine output as a result of that. We have the decreased blood flow to the GI tract, and remember, that's why we have that risk of the ileus. As far as decreased tissue perfusion to our cells, if our cells are out of energy, they can function on anaerobic metabolism, but only for a few short hours. 1 to 2 hours, we're going to have cell death. And so anaerobic metabolism will result in the body retaining lactic acid, and the lactic acid will produce that metabolic acidosis, that acidotic imbalance. And decreased tissue perfusion obviously can result in tissue damage and tissue necrosis, and then certainly cellular destruction and cell death. Okay, the last couple slides that I just want to talk about. This picture is actually, I highly encourage you to use your pharmacology textbook that has some really great diagrams on glaucoma and the pathophysiology. I'll just kind of orient you to the slide, and hopefully you can see this on your screen. But the very bottom circle is actually the lens. And then the black thing kind of coming out in the middle is the iris. And then the very top, rectangular image is the cornea. So you're looking at it, kind of the top is the outside of the eye, and then on down. And basically, if you look at kind of where the white arrow is starting, right behind the lens, we have basically our ciliary process, the ciliary body, or the anterior chamber. And again, the anterior chamber, ciliary body, was responsible for the production of the aqueous humor that we need within our eye. And so we have all the aqueous humor being kind of produced and released in that area, and we need an adequate amount of the aqueous humor, but we also need it to be able to have a outlet or a channel that it can actually not go out, so that it is not building up within the eye area. And so you'll see how the ciliary body, the arrow comes basically around the lens, around the iris, and then it actually about 90% goes through those little bumps or those ovals that signify the trabecular meshwork. The trabecular meshwork then is responsible for, well, it dumps into the canal of Schlemm and the episcleral veins, and that's how it's actually removed from that area. But bottom line, about 90% of the aqueous humor is the outlet is through the trabecular meshwork. So if, for example, we do have a trabecular meshwork that is closed, we will have a buildup of the aqueous humor, which will increase the intraocular pressure. Now, if you can look at the top of the diagram between the iris and the cornea, you'll see where there's about a 45-degree angle, just below the trabecular meshwork and above the iris. You see where that angle is 45 degrees. Now, normally we have about a 45-degree angle, and so this is where the glaucoma comes into play. If we have an open angle glaucoma, basically that angle is narrowed to anywhere 20 to 40 degrees. And if we have an angle that is narrowed, we certainly have a decreased ability of aqueous humor to be able to flow through that trabecular meshwork. And so that's what's happening with the open angle glaucoma. Now, if we have closed angle glaucoma, that angle is closed entirely or closed to, in that 10-degree or less range. And so we have a significant disruption in the outflow of the aqueous humor. And that is why we have a resultant in an elevated intraocular pressure and a true ocular emergency with closed angle glaucoma, because we have no way of getting any of that fluid out. 90% of it flows through that channel, that trabecular meshwork. So, bottom line, we need an angle of about 45 degrees between the iris and the cornea for an intact drainage system of aqueous humor. So with open angle glaucoma, again, this just kind of differentiates that we have an increased intraocular pressure over time. As that angle kind of narrows, we have a kind of a gradual buildup or increase of intraocular pressure. We have kind of a thickening and gradual obstruction in the trabecular network, and so the flow of that aqueous humor is obstructed. There is no closure of the angle, however. We do maintain an open angle, but it's just narrowed. Versus with closed angle glaucoma, we truly do have an ocular emergency where we have obstruction of the aqueous humor outflow. You will see that you have a much higher intraocular pressure, 50 to 70 versus the 30 to 50 that you saw on the last slide. And then also just remembering that the normal intraocular pressure was 10 to 21, just to give you that reference range. So hopefully this was helpful, and happy studying, and hopefully you'll be ready to do very well on the exam.